Great, thanks very much, Pete. And also thanks to the ABSS committee for the award. It's very much appreciated. Hopefully in the next 25 minutes, I'll convince you there's an evidence for a window of enhanced plasticity early after stroke. And I'll talk a little bit about what that means and where we've led on to some of the implications of that work and the future opportunities that we see from the study. So I'm sure everyone's very familiar with plasticity, but the definition that we use is the ability of the brain to reorganize in structure or function in response to behavior, environment, or injury. There are some other factors I just wanted to raise before we go too much further. So plasticity is a mechanism that's available to humans throughout life. But interestingly, the capacity for plasticity can actually be affected by different things. So that could be age. And for example, you see a baby on the bottom of the screen developing. For anyone that's had children, you've probably seen them learn new motor skills and learn to walk or crawl or whatever it is. And they certainly learn quite rapidly in those early stages of development. I was saying to Pete before that today is actually my birthday and I'm a little bit older these days. I'm trying to learn to skateboard and my plasticity is probably not as good as it used to be as my 7-year-old son who's picked it up very quickly. So, we do see those changes in plasticity over age and across development. And of course, what we're really interested in is what happens in injury. There's a few other things like genetics, physical activity, stress levels, and history of synaptic activity that can also influence the capacity for plasticity. I mentioned about injury and Pete mentioned that I'm a physiotherapist as well. So very much interested in stroke recovery and have worked in that space both clinically and in research for several years now. And often when students ask me what is a neurophysio, I think in some ways we're movement analyzers, but then re-educators as well. And some of the photos you see here where we're being mean to people. And in fact, neurophysios are a bit mean. This is supposed to be someone doing constraint-induced movement therapy. And we've actually, in this case, her stroke-affected arm would be her left arm. So we've taken away her right one. We said, you can't use that anymore. We're going to force you to use the stroke-affected arm. In this case, someone over here perhaps has altered balance after stroke. So we're really going to test their somatosensory and vestibular systems, their visual systems, which help maintain balance. And we do that over long periods of time in the hope that will drive not only behavioral changes, but plastic changes in the brain. So we can rewire connections, form new connections, and hopefully improve their behavioral outcome. But of course, something that could help us is if the brain was more amenable to change. So in other words, that capacity for neuroplasticity was enhanced. So a couple of key points before I get to the study. So plasticity describes the ability of the brain to change. It's a mechanism available throughout life, but it actually changes. The capacity for plasticity changes during critical periods. And it's fundamental for what we do is in rehabilitation after stroke, but certainly for any form of learning. And the question we're really interested in is there a period of heightened plasticity after stroke? Because that could really help us get better value for money, essentially, with our rehabilitation. We know stuff from preclinical models. So this is a study looking at, I think it was rats, and they're looking at from time 0 right through to about 30 days after stroke. The top line, this red or orange coloured line, is an increase in growth promoting factors, and that comes on quite early after stroke. And then the bottom section is an increase in growth inhibiting factors. So you see that's a little bit delayed compared to the growth promotion factors. And that opens up this critical period here in the middle, which is, they say, it's not precisely defined, but around 5 to 14 days after stroke in these rat models. We don't have similar neural evidence of enhanced plasticity in humans, but we do have behavioural data to suggest something similar might exist. So it's very common that after stroke, recovery is very rapid, certainly within the first few weeks and maybe even out to a couple of months after stroke. And it might be that rapid increase in behavioural restoration is underpinned by a period of enhanced plasticity. So we conducted a study with the primary aim to look for evidence of a similar change to what I was talking about in the animal models there, in synaptic plasticity in the human brains in the weeks to months after ischemic stroke. We did have a secondary aim that was looking at associations between plasticity and lesion location and recovery. But for the sake of time, I'm just going to talk about the first one. But I do just point out this is a published study and certainly available if you're interested. So I'll talk a little bit about the work now that we did. So we conducted a parallel study. So there was 2 data collection sites. Here in Adelaide, at the Royal Adelaide Hospital, we obtained the ipsilational data, and there was 8 assessment periods over a period of 12 months after stroke. They were weighted towards that first month. So there was actually 4 assessments within the first month, and then 4 assessments within the subsequent 11 months after stroke. And it was really, the decision to do that was based on the animal models where you see this heightened period of plasticity within days of injury. We also looked at the contralesional hemisphere, and this was done over in the UK in collaboration with John Rothwell's group. And we had 4 assessment time points there between 2 weeks and out to 26 weeks after stroke. Didn't matter which lab you went to or which hemisphere was tested. We did the exact same protocol in both locations. And to assess plasticity, we used what's called a spaced CTVS protocol. So it's an LTD-like protocol that repeatedly activates synaptic connections within the motor cortex, and it engages an early process of synaptic plasticity. And as I mentioned, it's a suppressive form of stimulation. So we used MEPs at baseline and then following the spaced CTVS protocol to get a measure of plasticity. So in other words, we're looking at baseline, you might have an MEP, for example, one here, which is around 1 millivolt in amplitude, but reduces down to about 0.5 millivolt after CTVS. And the hypothesis was that if at that particular time after stroke, the brain was more responsive to plasticity, so more capable of neuroplasticity, there would be a stronger CTVS response, so a stronger suppression of that baseline MEP. So we had 60 participants. There was a total of 300, just over 300 experimental sessions, and it's collected over 4 years. So quite a large a study really for this sort of work with stroke, and certainly in the acute phase after injury. I just wanted to point out as well, we actually had no adverse events. And keeping in mind that a significant portion of these studies, of the 300 experiments, were done within weeks of injury. So it is reassuring to note that it seems reasonably safe to use brain stimulation very early after stroke. We did, of course, select a suppressive protocol. And part of the reason for that is we were trying to, I guess, mitigate any potential effects of inducing seizures after stroke. So being suppressive, it's reducing excitability and hopefully wouldn't provoke a seizure, which didn't happen in this case. Mean age, very similar to many stroke studies, around in the 60s. I will say we're seeing younger and younger stroke survivors. So there were people in this study who were similar age to me, unfortunately. And to give you an idea of the type of people we had, so ipsilational data collected here in Adelaide, an ARAT score, which is a measure of upper limb behaviour. It's out of 57 and higher scores are better. And you can see the mean score at baseline was 48. So these were people that were relatively mildly impaired. And keeping in mind that the type of people we had to recruit were ones where we could get an MEP. So in other words, there was some functional integrity of their corticospinal tract. Over in the UK, so the contralational data, they use the Fugl-Meyer as their behavioural outcome. It's a measure of upper limb impairment, and it's scored out of 66. And again, higher scores are better. So you can see that these people are also pretty mildly impaired. Okay, and this is, I'll just talk you through these figures. So on the left is the ipsilational data, the right contralational, and we have our normalized CTVS response. So anything below this dotted horizontal line is a suppression of the MEP. Now we did have different dates that we were collecting the data, but for graphical purposes to compare between the 2 hemispheres, we've banded them into anything from 0 to 14 and then from 15 to 30, and you can see across there, just so that it's sort of similar to have a look between the 2 hemispheres. So with the ipsilational data, we didn't really see much of a response, certainly a CTVS response anyway. And you can see there that it was relatively consistent over the entire period. And in fact, statistically speaking, when we actually looked at when the exact date that each assessment was performed, there was no significant effect of session or time point. We also went on to look to see whether having a cortical lesion as opposed to a subcortical lesion might actually affect this response. And the reason we did that is we thought that people with cortical lesions might not respond as well to ipsilational CTVS, but again, there was no effective lesion location. Over in the contralational hemisphere, this is what we found. So early on after stroke, there was this decrease in MEP amplitude, which is what we would expect. So we suggest that indicates that the CTVS response was significantly greater early after stroke. And in fact, when we did the statistical analysis, there was a time point by session interaction. So here's the key findings, and I'll unpack them a little bit in a minute. So this was a multi-site longitudinal study, quantified plasticity in the human motor cortex within days and weeks of injury. So our plasticity measure was a transient reduction in corticospinal excitability produced by a spaced CTVS protocol. And it was strongest around 2 weeks after stroke in the contralesional hemisphere. And there was no change in response over in the ipsilesional hemisphere. So from our point of view, we think this demonstrates for the first time as well, a time-limited form of post-stroke cortical plasticity in humans. As I mentioned, I just want to unpack these a little bit more. So I'll start with this one. So how do we know that this is definitely a measure of plasticity? So the first thing we would say is that with pharmacology, we've been able to demonstrate, or previous studies have demonstrated, that the response to CTVS is NMDA receptor dependent. And therefore, it seems likely that that short-term LTD-like response that we see after CTVS is likely an influence of this efficacy of synaptic connections. We also know from recordings of corticospinal volleys evoked from single pulse TMS during that period of reduced excitability, that it seems likely the site of activation is within the cerebral cortex. So if you take those two pieces of information together, it gives us some sort of indication that CTVS reduces the excitability of the intrinsic circuits of the motor cortex. So it's some indication of synaptic plasticity. What about this one? So strongest at 2 weeks after stroke in the contralesional hemisphere. As I've mentioned a couple of times, we used what's called a spaced CTVS protocol. And one of the reasons was it's actually got reasonably good intra-subject reliability in healthy adults, that is. So in other words, it's interesting that we've done these repeated measures using spaced CTVS in the same people over several weeks and months after stroke, but the response changes over time. And if we have good intra-subject reliability, it probably suggests that there is a change in capacity for neuroplasticity and that it's greater early after stroke. Again, we're reasonably confident in this finding, given that it's similar to what we see with preclinical models. They do tend to show widespread, so in other words, ipsilesional and contralesional hemisphere changes, and that it is time limited as well, just as we see here, where we have that increase in CTVS response early after stroke and it dissipates over time. We thought this one was interesting as well, that there's no change in response to CTVS over time in that ipsilesional hemisphere. So I'll just unpack that a little. I mentioned in the previous 2 slides now that in preclinical models, there's widespread changes. In actual fact, the most robust and significant changes they see is actually in the ipsilesional hemisphere. We obviously know with more mild to moderate impairments, it's the ipsilesional hemisphere as well that reorganizes. And keeping in mind, that's the type of people this study was done on. So very mild impairments of the upper limb. They had a functioning CST from the ipsilesional hemisphere because we were getting MEPs very early after stroke. So one explanation is perhaps it's to do with the type of plasticity. So we've used spaced CTVS, which is an LTD-like protocol, so suppressive. And it might be, and we know that both strengthening and weakening of synapses is important for stroke recovery, but we think it's possible that after stroke in the ipsilesional hemisphere, that balance is biased towards more of an LTP-like response. So it could have been if we used an LTV protocol, whether that's ITBS or something else, that we might have seen a period of plasticity in this hemisphere. We don't know. And as I mentioned, we used the LTD-like protocol, the suppressive protocol, from a safety grounds point of view. But it could also be related to many of our participants having cortical lesions. I did mention that we tested for that and we didn't see an effect of lesion location, but it's something that we think still could have influenced the data because it was actually a very high proportion that had cortical involvement. So what does this mean? So I guess graphically, there's figures very similar to this getting around that show, after a stroke in the red line, there's this sudden decrease in motor function, and that slowly recovers over time. And in fact, for most people, they say it's about 70% of motor function will come back. And it seems likely that this is underpinned by what we found, this greater increase in plasticity early after stroke. So this time-limited enhanced window of plasticity. We're really pleased from a clinical implications and a message getting out there to clinicians that the APA is actually taken the story on board and funded a short 90-second video, which is going to be released in the week before Stroke Week, which I think is National Stroke Week, so I think coming up in August. So keep an eye on social media. You'll probably see it on my channel or any of the APA channels, that they will actually release that video. It's a 90-second video summarising the study. A couple of questions that I'm personally interested in is, what can we do here? So can we do something to prolong that window of enhanced plasticity? And does that then encourage or enable greater recovery after stroke? Another question, which I'm probably slightly more interested in just at a personal level, is can we reopen a period of enhanced plasticity at a later time? So in chronic stroke survivors. And if we did that, does that then support their recovery even further? So I'm going to jump into what my research program is, which I hope is okay. And I'm going to talk about a couple of little studies that's followed on from that. What I'm really interested in is strategies to improve stroke outcomes. And the first thing in my program of research, I look at investigating and understanding potential solutions to this problem. So things that I'm interested in, and it's underpinned by the study I've just spoken about, is enhancing things that we can do to enhance neuroplasticity. So we've looked at virtual reality-based motor imagery, obviously non-invasive brain stimulation. We've just started a study today, actually, with exercise. And there's a couple of other things happening there as well. We're doing a body of work around concurrent impairments. We find that after stroke, many people have fatigue, they could have post-stroke depression, and they're kind of silent impairments that people tend to ignore, but it clearly impacts the capacity to engage in rehabilitation and therefore improve outcomes after stroke. So we certainly run studies around post-stroke depression, and we're obviously interested in biomarkers and mechanisms of any of these things here. Once we've found a solution that we think might work, we go and test that, predominantly in clinical trials. And if that works, we have an avenue for implementation. And that's based around our technology clinic, which we have here at the university. It's a student-led clinic predominantly, although myself and one of the other physios do jump in occasionally. And I'll talk a bit more about the clinic in a minute, if you like. There's a couple of other things. We're really interested in patients' values as well. So once we implement some of these solutions to help the recovery, do they actually even like what we do? Yes, we go through studies and it's very tight inclusion criteria. It's actually feasible in clinical practice. So we have an avenue now as well to reevaluate the problem. Have we actually solved the problem when we go to implement it? This is from a different presentation that I've cut this slide from, but we have lots of collaborators. But I did want to say, always looking for any others if people are interested, so do drop me an email. And I'll quickly, I think I've got time to talk about these two things here. So we ran a trial, probably finished just pre-COVID, I think, and it was looking at TDCS to reopen a period of enhanced plasticity. So we specifically sought chronic stroke survivors, so people outside of that window of enhanced plasticity. We did a home-based brain stimulation study, which was interesting because it was pre-COVID, but would have worked very well during COVID. And they completed 14 sessions of nodal TDCS at home, plus an upper limb rehab program. So it's called the Graded Repetitive Supplementary Program, the GRASP program. And they have a series of exercises tailored to their level of impairment that they perform. We remotely monitored the sessions, which you can actually see me on the iPad here talking to a pretend participant, not a real one. And we're making sure that everything's set up correctly, that they're ready to go, that the exercises are appropriate still, checking any issues, etc. The other thing is, for this study, people had to have a family member or carer that we actually trained on how to use the device. It's very simple. You can see it's just a single button to start it. It's more difficult to place the electrodes in the right spot. And a series of behavioural and physiological measures, both at baseline and then after treatment and a follow-up. So this is what we found. Okay, so people that had the sham stimulation. So in other words, all they did was 14 one-hour sessions of the upper limb program. They popped the stimulator on, but it didn't do anything. So at baseline, here, this is a change in the Fugel-Meyer score. I had a 1-point improvement after the treatment, just from doing 14 hours of exercise. That's pretty common. We're not surprised by that. And the reason I say that is to actually induce meaningful change in upper limb impairment in chronic stroke survivors requires an incredible high amount of dose of therapy. So 14 hours is not enough to really change any sort of upper limb impairment. But the people that had the active stimulation is obviously what we're interested in. So they had a clinically meaningful change. But the thing that's interesting, and it's also statistically significant, the thing that's interesting is that even after the treatment, they continue to improve. So it's 4-point improvement there, 5-point, and then out to a 6-point improvement 3 months after the treatment. So they're not getting any stimulation for those 3 months, but they've continued to improve. We ran some MRI, pre and post only, not any of the follow-up sessions. And this is just the active group. So this is a group average for there's about 30 people in the active treatment group. And this is their resting state motor network prior to stimulation and then after stimulation. So you can see I haven't changed the slice or anything like that. It's just a change in the activation of that resting state network. Okay, and very quickly, so implementation to clinical practice. So we offer these treatments that we've investigated and we've tested. And if we think that they're effective, we have an avenue to then offer that to the community. And part of the reason actually is we've had people say to us, it's almost like it's the university's responsibility. And I'm not sure I agree with that, but there was a lot of pressure in some instances to say, we've helped us so much, but it was just 2 weeks of therapy. So now what can we do? Where can we get this treatment to improve my recovery? So that was a motivating factor. But it also gives us greater research opportunities. We have really keen participants coming into the clinic who are happy to try anything new when we've got those ideas that we want to test and evaluate. We have students coming through the clinic on placement. So they're on their 3rd year rehab placement in physiotherapy, and they can deliver some of the traditional therapies, but actually get some exposure to new technologies. So the type of things we have there and the things that you're most interested in are probably around brain stimulation. So we have one on wheels. This is actually the stimulator we use up there. And we also use the TDCS device. So in some cases, we will include that if it's appropriate for that person to be included. We also, as you can see, VR, some upper limb stuff, and we've recently just been given some robotic devices, which people can play games against each other. So they're up in the clinic. So yeah, we're really excited about that. As I mentioned, we get feedback from people. We reevaluate this sort of stuff as well and see whether this is actually being beneficial to them. Do they enjoy it? Is it something that people like? And also, what do the students think? But of course, I didn't do everything here, and there's a lot of help and acknowledgements that go out to everyone else involved. And Pete, I think I've done it in less than 25.
Absolutely brilliant. Thank you so much, Brenton. Right on time, and look, a really fantastic program of research. Very exciting data coming there also. So yeah, look, you must be absolutely thrilled with how that's going. Please do get your questions in the Q&A box, and I'll get those to you. But I might start out, if that's okay, Brenton. I just wonder where you stand in terms of the site of stimulation and ipsilational versus contralational stimulation for stroke. I know there's been a bit of controversy. What's your take on this?
Yeah, so great question, and probably something that I wanted to put in my presentation, but I forgot because I was working on a study this morning. We recently published an article in Neurology around factors that influence the response to TDCS in people with stroke, and proposed a theoretical patient-tailored model. So we have a model in there which, in some instances, depending on the patient's presentation, we wouldn't do your traditional ipsilational anodal stimulation and contralational cathodal. And in fact, from memory, it's probably more your severely impaired ones where we'd actually look at alternative approaches, such as facilitating the contralational hemisphere, for example. So the students that come through, when they say, look, I'd really like to try brain stimulation with Mr. X, for example, we go through a process with trying to determine whether the corticospinal tract is still intact. So we try and tailor it a little bit to the individual client. Now, some of them have been in studies, so we've got MRI data. We can tailor it quite well to that person. In other instances, we can use TMS to measure the CST integrity, obviously. And again, that's sort of helping us tailor that treatment a little bit better, rather than your one-size-fits-all approach of, as you mentioned, the facilitating the ipsilational hemisphere. So it's good for the students to actually try and think, what's the clinical presentation here, and then how would I actually adapt the treatment best to this person. So yeah, I don't sit on the one size fits all. I think we do need to tailor approaches, and we try and do it based on what we published in neurology.
Great, great. We're getting some questions coming through. We've got a few minutes for these. So first of all, from Martin Sale. So he says, Brenton, did you assess spatial attention in your stroke cohort? I wonder whether there were differences in the responses in those with spatial neglect compared to those without.
Yeah, is this, sorry, I kind of presented two studies, Martin. Is this to do with the one that was the TDCS at home, or is this the plasticity after stroke? Or I could answer both if you like.
Yeah, I think maybe answer both.
Yeah,
it
sure.
might be a bit hard
so,
to get the
yeah,
back and forth.
So plasticity early after stroke, because we recruited people within days of injury, it was hard for us to know. So some people within that would have developed neglect and spatial inattentions. And the thing I would say about that is we were probably more interested in the physiology, so less concerned about that being an issue. I think Martin's question might be relating to the home TDCS and the chronic stroke survivors. And an inclusion criteria there was that they weren't to have any spatial neglect because they had to actually perform exercises and they needed to have attention to the affected side. So that was a exclusion criteria, if you like.
And another question, this is from Nigel Rogash, who says, fantastic talk, Brenton, amazing results for the home study. Did you measure whether the active group engaged in more therapy in the post-treatment period, and could this have contributed to the continued improvements?
Yeah, so I've got a lot of data, which is why it's taking me a while to publish it. How long they spent on Skype, for example, talking to us. So it's going to take a while. We've even got qualitative stuff afterwards, and that's where I think we'll get that answer out. Anecdotally, having a listen to some of those interviews, people, it's not that they continued with the GRASP program, it's just that it reopened more opportunities for them to do stuff in the community. So for example, if you couldn't turn the light switch on or butter your toast in the morning with your affected arm, but getting a 4 or 5 improvement on that scale allowed you to do a few of those things, it meant that they kept doing it after the study. So in other words, it gave them more use of their arm and they kept using the arm. We encourage people that when they had improvements, that, you know, if your arm improved, keep doing stuff with it because you don't want it to disappear again. And it is that use it or lose it sort of attitude.
One very, very quick last question. Timothy Carroll says, thanks for the talk. Do you have any ideas about why TDCS might open up a plasticity window reminiscent to the early period post-stroke? And what do you think the TDCS might be doing?
Yeah, so it's an interesting question because so Mitch Goldsworthy and I have recently published a study in Cortex talking about what, it's a bit different, but theta burst in RTMS does, and whether it actually does do what we think it does, or does it increase neural noise. And I don't think we fully understand the mechanisms of brain stimulation at the moment. And I know that we think TDCS changes membrane potentials, but I guess we're getting at the point that we're trying to do something that might excite the brain, increase activity, which we did measure MEPs, and I must say it's interesting, we didn't see an increase in MEP amplitude in those people, so before and after the stimulation. So I gave you a very small taste of that study. That's something else that's interesting. Look, I don't know is the shortest answer, and I'm happy to discuss that further. Yeah, that's probably best.
Thanks, Brenton. We'll draw it to a close there for you, Brenton. Congratulations again on the award, and that was a fantastic presentation. Best of luck with the continued success of that really important research program.